Hey, 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 it's Dr. Shelley, and today we have a complex lecture. Yes, we do. It's shock. Oh my God, yeah. So I'm Dr. Shelley with Shelley's Nursing Review and, of course, HETV. You might want to give me a text for resources later if you need them. I will just say my number here is always up at the top of the board, 216-410-0936. Text message me if you need anything. But for now, let's get busy with shock. It is a very complex system of diseases, right? It's like a really bad thing. And there are lots of different types of shock, right? So if you look up here, I'm going to start with just giving you a really brief explanation of all the shocks, and I think it will help you in some of your tests, but we go into detail about each shock later. So for right now, let's look at just what we're dealing with. We have 6 types of shocks, 3 of which fit into an umbrella category called distributive shock. It's not a big deal, but just know that. So here we go. Look at this. Septic shock is the deadliest. It is the most serious. It kills more than heart attacks and strokes. 1 in 3 hospital deaths are related to septic shock. So it is really, really, really bad. It is very difficult to treat. It can be very subtle. When a patient has septic shock or even sepsis, one of the giveaways as to what type of shock this would be is you're going to have a high white blood count, you're going to have a fever, and in this case, this patient will be, their skin will be more warm instead of cool like most shocks. Theirs will be flushed, red, not pale, and warm. That is the way this shock differs from all the others. I'm going to say that again. The way the septic shock differs from all the others is that the skin is warm and red or flushed, and the white blood count will be high and the fever, especially in the early stages of shock, septic shock. Don't forget, as you go late into the signs of septic shock, that can be really weird because then your temperature can go down and you can't keep it up. And also your white blood count can get all used up and that goes down as well, but you get it. Now, the next shock is anaphylactic shock. And this is the fastest shock, right? It's fast. So if you have to think about how does anaphylactic shock differ from all the other types of shock, it's fast. It occurs within 15 to 30 minutes of exposure to an allergen. This patient was exposed to something that they have a hypersensitivity to or an allergy to. Don't forget the mnemonic of black. The mnemonic of black is B for bananas, L for latex, A for avocados, C for chestnuts or any nuts, and then the K is for kiwi or any citrus. Black, right? Those substances in that mnemonic can cause a lot of people to have an anaphylactic reaction. Throw in there for good measure seafood, penicillin, eggs, and bumblebees. Anaphylactic shock, right? My grandson had this when he ate Reese's Pieces for the first time at 3 or 4 years old, and you know, we found out the hard way he's deathly allergic to nuts. So thank God he's still here with us, but it was very severe. Neurogenic shock is where you have a shock from a spinal cord injury of T6 and higher. This patient is definitely a quadriplegic. It is a stimulation, it is a loss of the sympathetic nervous system. And the way you know the neurogenic shock from all the other shocks is all vital signs are low. The temp, the pulse, the respiratory rate, the blood pressure, I'll say it again. All vital signs are low, okay? So that's a big deal. Septic, anaphylactic, and neurogenic shocks make up something of an umbrella term called distributive shock. Distributive shock is just an umbrella term to describe shocks in which there's massive vasodilation and fluid shift. Okay. The next shock is cardiogenic shock. I find that this is the easiest shock for students because if they just remember to look at the word like I taught you, and that is cardiogen, whatever this is being generated, or this generates whatever this is. So if it's a cardiogenic shock, then a cardiac problem probably generated it in the first place, right? See, we got this. Now, what kind of cardio problems could have led to cardiogenic shock? That's easy. An MI, or myocardial infarction, which is what? A heart attack, which is not the same thing as a cardiac arrest. So don't confuse those in your mind. So either a heart attack, which is your myocardial infarction, or CHF, congestive heart failure. Now, sometimes they're sneaky, right? Maybe they want to be a little sneaky with you on the test, and they say instead an ST elevated MI or STEMI, or they say something like acute coronary syndrome. Always remember, as long as it's got cardiac in its meaning, it could have caused this patient to go into cardiogenic shock. One of the most common shocks is hypovolemic shock. It is probably the one that nursing students feel the most comfortable with and kind of feel like, oh, I get that. I can kind of understand that. The hypovolemic shock just means that the what? The volume in the body has gone down, and that could be the volume of fluid, water, blood, whatever. But whatever it is, the fluid in the body has gone down. Some type of fluid has gone down. So in a hemorrhage situation, like through trauma, gunshot wound to the abdomen, pelvic fractures, two big common types of trauma that can lead to hemorrhage. Burns, your burn patient loses a tremendous amount of fluid. A patient suffering with a severe GI illness where they're vomiting and having diarrhea nonstop. An example of that would be cholera, the diarrhea that kills you within 18 hours, right? And of course, the number one for most nursing students is post-op patients or surgery patients right in the surgical suite. And we know that hemorrhage is one of the most common deadly complications of surgery. So hypovolemic shock makes sense, okay? And you know what's going to happen here. You're going to see the hemoglobin and hematocrit drop. With cardiogenic shock, you're going to see the patient have troponins. You're going to see that the BNP or B-type natriuretic peptide is high, okay? So, you know, you got it. You get it. All right, now the last one and the rarest form of shock, one that probably you've never even heard of, therefore I wouldn't tend to want you to remember it, but it's not completely honest if I don't give it to you, right? So the rare type of shock is called obstructive shock. And this is where there's an obstruction of some sort, like with the pulmonary embolism. You know that there's a clot stuck in the pulmonary artery. Perhaps it's a pneumothorax, a tension pneumothorax, where one lung has collapsed. It could even be a cardiac tamponade where the heart can't even pump because it's being compressed by blood and fluid, especially after cardiac surgery like cabbage. Okay. All right. So these are all of your types of shocks. So I think you get it. Now let's go a little deeper. What exactly is shock? Shock is decreased tissue and organ, all organs, decreased tissue and organ perfusion due to a decrease in the mean arterial pressure less than 65. Now, why? Well, the mean arterial pressure directly relates to blood pressure. And in all shock, did you hear what I said? I said all shock. One more again. All shock, fool. All shock has a low blood pressure. Oh, if you don't take nothing home with you today from me in this video, you better remember that shit. All shock has a low blood pressure. Now, don't let me hear you out there saying, and all shock got tachycardia. No, that's not true. I just told your ass that neurogenic shock has all vital signs low. In fact, if you've really been following me in all my videos, over 500 of them, you know that when you get to the neuro system, the pulse is always low. Okay. All right. So anyway, all shock has a low blood pressure. That you can take it to the bank, cash that motherfucker out. Okay. All right. So blood pressure is low with shock. Now that's our first issue because we're saying, what is it? Well, that's it. That's the primary issue. You have a decrease in circulation of blood to everything. Now, the next thing you must know about shock, this shit is deadly, y'all. You could die. Yeah. So what do you usually die from? Well, you could die from acute respiratory distress syndrome, or you could die, and that's ARDS, not ERDS, ARDS, or you could die from DIC, disseminated intravascular coagulation, or you could die from MODS, which is multiple organ dysfunction syndrome, okay? So that could be the cause of your death, or worse, all of them, okay? Now, number 3, because we're digging deep here, y'all. Here we go. It's called pathophysiology or physiological adaptation on your CPR report. Number 3, shock is an inflammatory process with massive vasodilation. These are 2 blood vessels. They are open. See, they're open. Okay. If you have massive vasodilation, they're super open, and that means your blood pressure goes down. If, on the other hand, you have vasoconstriction, blood pressure goes up. Now, you got to know that. Blood pressure is controlled by vasodilation or constriction and by fluid volume. With shock, I'm telling you that there is massive vasodilation and the blood pressure drops because guess what? If you were vasoconstricted, it would take a lot of pressure. Watch this. It would take a lot of pressure to push blood through that teeny tiny itty bitty vessel. If you are vasodilated, it doesn't take any pressure at all to shove blood through that vessel. So your blood pressure drops. Number 4, because there's decreased perfusion, blood circulating to tissue and all your organs, your cells start to become what we call hypoxic, which means there's just decreased oxygen to those cells. Because you don't have enough oxygen to continue working your body the way it's supposed to go, but your body still must continue to live, the body switches off from aerobic to anaerobic metabolism. Let me explain. Think about it like this. If I say aerobic, air, I want you to think of aerobic as air. And what is air? Oxygen. And you remember this little English lesson? A before a word or AN before a word means without air. Means without, right? So watch this. You don't have any air or oxygen, so the body switches its level of metabolism to anaerobic, or AN before a word means without. So now we are operating our body on an anaerobic metabolism, which means without air or without oxygen. And what happens when you switch over to anaerobic metabolism is your body creates something called lactic acid. When you create lactic acid, you know that metabolic acidosis is coming your way. That makes sense. Now, so we can actually test for this. We get a serum lactate level and we say over 2 is very concerning. Okay, this is when we start thinking, oh my God, we're going into some type of shock, usually septic shock, okay? You see that, as I alluded to, number 5 says metabolic acidosis. Don't forget your basics. Whenever I'm talking about acidosis, the potassium is high. When I'm talking about alkalosis, watch this. If I'm talking about alkalosis, which, by the way, I'm not. I'm talking about acidosis. But if I'm talking about alkalosis, which is the opposite, you just want to remember with alkalosis, all K is low. How you like me now? So again, this is a buildup of lactic acid because we switched from aerobic metabolism, which was air and oxygen, to anaerobic metabolism, which is without air or oxygen. And that helped us, unfortunately, create and produce lactic acid, which served to help us go into metabolic acidosis, not alkalosis. And every patient in acidosis, that potassium is high. You can take that to the bank and cash it out too. Okay, so we got to move on, y'all, because we're doing pretty good, okay? We're doing damn good up in here. Now, what I'm going to do is I'm going to erase this, okay? Real quick review. Septic shock, fever, infection, high white blood count, warm, flushed skin. Anaphylactic shock is going to happen fast, within 15 to 30 minutes. The patient's going to have mouth and face complaints after eating something or being exposed to an allergen. This patient will wheeze, you know that. The airway is in trouble. Neurogenic shock, all vital signs low because you lose your sympathetic nervous system with any spinal cord injury above T6. The patient's posture is flaccid. Cardiogenic shock has to be caused by a pre-existing cardiac issue like a heart attack, which is an MI, or congestive heart failure, which is your CHF. The BNP, which is your B-type natriuretic peptide, and your troponins will be elevated here. Hypovolemic shock is where you have either lost blood or fluid. It could be through trauma, burns, GI conditions like cholera, some severe diarrhea and vomiting, or even surgery. The H&H, or hemoglobin and hematocrit, will be low. Obstructive shock is extremely rare. You're talking pulmonary embolism, cardiac tamponade, or pneumothorax. So that's good. Now we're done with that, okay? Now, just a quick review. I asked you, what is shock, right? What exactly is it? Well, we concluded that it is decreased perfusion to organs and tissue, all your organs, and this decreased perfusion is due to a mean arterial pressure drop less than 65, and that stemmed from the fact that all blood pressure is low with shock. So we can erase that. What else is shock? Shock is deadly. How do you die? You die from ARDS, DIC, and MODS, or multiple organ dysfunction syndrome. What else is shock? It's inflammatory. And inflammatory or inflammation causes vasodilation, and massive vasodilation serves to decrease the blood pressure. So that is what shock is. Now, we have other things that shock is, and you have to remember this for whatever test. Shock is anaerobic metabolism with an increase in lactic acid, and that sometimes is the lab we use to see, oh shit, you're going into shock. It will create a metabolic acidosis where the pH is low, and we're not talking about alkalosis, which is the opposite. Every time you have acidosis, the potassium is going to be high. Okay, that was a quick review. Now we're going to look at the stages of shock. When we look at the stages of shock, there are 4 stages. There is the initial stage. And let me just erase this part here so you don't get all confused. But there is the initial stage of shock. There is the compensatory stage of shock. There is the progressive stage of shock. And then there is this refractory stage of shock. So we're going to go piecemeal it one at a time. And this is where the nurse's understanding of anatomy and physiology really helps. Sometimes I often say that the nurse who doesn't really understand anatomy and physiology or didn't have a great teacher, and therefore he or she did not get a firm grasp of the concepts, this is going to be a little difficult for you, so I'll try to keep it as simple as I can because it's a lot of anatomy and physiology. It's a lot of understanding what each organ in the body is supposed to do and how shock affects it. So we're going to start off with just the initial stage of shock. The initial stage of shock, basically anything in this initial stage of shock, the signs and symptoms would depend on the type of shock, but there's a few things that most shock will have. Most shock, not all, will have tachycardia, tachypnea. All shocks will have a low blood pressure, acute kidney injury, high K, renal failure, oliguria. All shock tends to have those types of things, okay? And that's kind of important because those are things that you should be like early signs, right? Initial. What's happening during the initial stage of shock? We have that decreased tissue and organ perfusion, the increased lactic acid, the decreased blood pressure and mean arterial pressure, and all of it is due to massive vasodilation, okay? Our body is not a punk because God made no mistake. So our body looks at all this hot ass mess you got going on, and our baroreceptors, which are found off the aorta. If you think about the biggest artery in your body is the aorta, but off the aorta are little trumpet holes, and they go to the carotid artery and any other arteries and whatnot. Well, there are baroreceptors to pick up on the fact that this blood pressure is low, and those baroreceptors take that information first to the neurological system or your brain. Here's how your body responds to shock in the compensatory stage. In the compensatory stage, the neural system kicks in the sympathetic neural system or sympathetic nervous system. And remember, this is your fight or flight. So you are definitely stressed, and this is your fight or flight. The parasympathetic nervous system, which is not part of this, the parasympathetic nervous system is a rest and digest. Sympathetic nervous system is fight or flight, okay? So the fight or flight stress response has kicked in. And if you've been in my class for longer than 2 seconds, you know there's a fancy word that starts with the C that is released in the body. This word is called catecholamines. Catecholamines include epi and norepi. Epinephrine and norepinephrine. So catecholamines, epinephrine and norepinephrine are also names for adrenaline. When these catecholamines, epinephrine and norepinephrine are released, they try to fix the problem with the massive vasodilation by causing vasoconstriction. Then, if you think about what I said earlier, vasoconstriction will increase the blood pressure and increase the pulse. Now, those catecholamines, or the norepi and the epi, they are eventually going to stimulate the adrenals, and the adrenals are going to go ahead and put out aldosterone. Aldosterone is going to be like a steroid, because listen, if the adrenals put out aldosterone, that sounds suspiciously a lot like steroid, and aldosterone does exactly what steroids do. And this aldosterone will also serve to increase the blood sugar, the blood pressure, and it will increase sodium and water retention. Aldosterone, steroids. What do steroids do? Increase blood sugar, increase sodium and water retention, increase blood pressure. Now remember what we said, with all shock, the blood pressure is low, so an increase would be good here, so don't forget about that. So that is the role that the neurological system or the neural system plays in shock. The next part of your body that's going to respond to shock is the renal system. The kidneys are like, what the fuck are you doing? I need blood perfusion. In fact, I told you guys a long time ago, no BP equals no PP. In other words, beloved, if you don't have any blood pressure, then you don't have any blood perfusing, BP, blood pressure, BP, blood perfusing, BP. No BP means no blood perfusing the kidneys and all the other organs in your body, but right now we're talking about kidneys. So with no blood perfusing the kidneys, we have the no BP equals no PP, and then we have a kick in, a kick off, a start of, if you will, of the RAS system. This is your renin, angiotensin, aldosterone syndrome. The kidneys are going to start with the production of renin. Renin, renal. Renal is kidneys. The kidneys are going to put out renin, a hormone, which has a purpose of stimulating the release of angiotensin. So it's going to stimulate the liver, do a few things, get angiotensin going. You know there's something called angiotensin 1 and angiotensin 2. And the angiotensin 1 is converted into angiotensin II with the use of the lungs. So this type of conversion is done in the lungs. And the way it's converted from angiotensin I into angiotensin II is we use an angiotensin converting enzyme, ACE, right? Okay, that's important. Let's do a little side note just for you to understand the bigger picture. If your patient's on an ACE inhibitor, then this whole thing is inhibited. So if we are trying to take a patient in shock with a low blood pressure and we're trying to raise it, we're going to need a RAS syndrome. If we are trying to take a patient with a high blood pressure and lower it, we're going to need an ACE inhibitor because it'll stop this. The problem with the ACE inhibitor is the number one side effect is a dry cough. Well, why did that happen? Well, I just told you. Angiotensin I is converted to angiotensin II in the lungs. ACE inhibitors must then work in the lungs to stop it. And in the lungs is where you get the dry cough. That was for free. Okay, now, so you have it. Now, when the kidneys start doing their thing and putting out the renin, and then the renin stimulates the liver to go ahead and get the angiotensin I produced, and it's converted into angiotensin II in the lungs. The angiotensin II will stimulate aldosterone, which I already told you is like a steroid, once again, causing sodium and water retention, and also causing high blood pressure, and also causing high blood sugar. Blood sugar would be good. You need energy, but at this point in your life, it might not be as good as we like it to be. Normally in a stress response, fight or flight, blood sugar is great, but you're really sick, and blood sugar being this high could be DKA for the type 1, HHS for the type 2. So at any rate, we're talking about the RAS, right? The renin, the angiotensin, the aldosterone syndrome. Once the angiotensin II stimulates the adrenals to put aldosterone out, it also stimulates the pituitary to put ADH out. And the reason why the ADH, or the antidiuretic hormone, the reason why this was secreted is antidiuretic hormone responded to the increased concentration of the urine. Remember that it responded to the increased concentration of the urine, and it responded to the increased sodium in the blood. So aldosterone caused you to retain sodium and water, but the salt in the blood made the ADH come out, and it also triggered your thirst. So now we have an antidiuretic hormone, and with an antidiuretic hormone, the body is trying to retain fluid and make sure it dilutes the salt in the blood. But then if you're retaining fluid from the antidiuretic hormone, this fluid is not always a good thing, and you'll see that with a lot of edema and stuff like that. So you got it. It's a little complex. I hope you're listening. Just know that this ADH, this whole ADH, antidiuretic hormone, means you're not peeing. The RAS system means you're not peeing. You have sodium and water retention, remember? And your blood pressure's going up and all this nonsense. And this is to help you. Remember, this is actually to help you not die from low blood pressure. So all of this is going the way it should for compensation. Okay. Now, the patient may start to have problems with the kidneys, and if they start to have problems with the kidneys failing, then we're going to see a high K, and we can also see acute tubular necrosis or death to the structures of the kidneys. So that's going to be later. Let's look at the compensation in the GI system. And the GI system goes with a lot of the other systems in terms of why is this happening. But let's think about what's going on. When you are in a stress response of fight or flight and you are in shock, your body wants to make sure it maximizes whatever oxygen and blood flow it can get, which isn't much, and give it to the most important parts of the body, the brain and the heart. So it takes blood from your arms, it takes blood from your legs, and it takes blood from all the other parts of your body that doesn't need to work right now. It even took the blood from the kidneys. It takes the blood from the gut. And this is where we get to the GI system. So if you take all the blood from my gut and you shunt that blood to my brain and my heart, then my GI system, after you shunted all the blood away from it and decreased the perfusion, it will no longer move and digest food. In fact, whatever was in there at the time is going to just stay right there, building up acid, eroding the tissues. This movement of the gut is called what? Peristalsis. And so there's no peristalsis. Everything is sitting still in all this acid. And what that does is it can cause a paralytic ileus. Now don't get your panties in a bunch. Look at the word. Paralyzed ileus. Paralyzed ileus. Your ileus is your small intestine or your bowel. Paralyzed means basically a bowel obstruction. So you're getting a bowel obstruction from you going through shock because the digestive system is not considered important enough to try to save, because you can live without digestive system. And with all the acid just sitting there, you're going to get ulcers. So ulcers are going to be eating the lining of, the acid's going to be eating the lining. You're going to get these ulcers. It's really bad. Okay, so that's just from shock. All right, moving on. The respiratory system is going to try to compensate by increasing the rate, being maybe deep at first, but then ultimately you're not going to be able to keep that up and you're going to become shallow, but definitely rapid. So this patient has tachypnea, and this patient having this tachypnea is due to the metabolic acidosis. Many times these patients could even need a vent because their respiratory effort is poor. So just remember the respiratory rate will increase. For the skin, this is important because it's a little different for septic shock, but all the other shocks, the skin will be cool, clammy, and pale, or in the African American, ashen, darker complected patients. And the skin will be very edematous due to capillary permeability, which we'll talk about. Okay, so the skin is sometimes a telltale sign. Here's another thing I tell my students, that if their patient is clammy, perspiring, sweating, diaphoretic, it's an emergency anyway. I promise you, there are only 5 reasons why your patient's skin is wet, damp, clammy, perspiring, diaphoretic. Ugh. There are only 5 reasons, and they're all deadly. Those 5 reasons are heart attack, stroke, pulmonary embolism, shock, which is what we're talking about, or hypoglycemia. All of these things will kill you. Okay, so you want to pay attention to that skin. It's not cool at all. All right. Now the liver is also not being perfused. And because the liver is not being perfused, you have decreased function, decreased clotting factors, buildup of toxins, including ammonia and bilirubin. Because remember what bilirubin was? Bilirubin was just dead red blood cells, right? And so remember how the anatomy and physiology goes. The spleen is on your left side, and in the spleen, For the spleen, the purpose of the spleen is to be a garbage can for dead red blood cells and the vacuum cleaner for any bacteria in the blood. Well, the spleen shares circulation with the liver and sends over the dead red blood cells so that the liver can make bilirubin, and bilirubin gives the color to your stool. And of course, we excrete it so we don't maintain this orange color. So remember what I teach you. Bilirubin is the death of red blood cells that can give you a yellow or orange color if you can't get rid of it. Okay, that'll hit you later with other topics. All right, now, the lungs. The lungs aren't being perfused either, you guys. And so with the lungs, we have a decreased gas exchange. Don't forget that the gas exchange in the lungs happens in the tiniest sacs, air sacs in the lungs called the alveoli. Well, here you have a decreased gas exchange. You have an increased respiratory rate. You have a VQ mismatch, which is a little deeper than I want to go to in this video. And then you have a collapse of the alveoli where this gas exchange was supposed to take place. And this collapse of the alveoli is called atelectasis. And that's going to get worse. But remember, we're still in compensation. We haven't gotten worse yet. We're still trying to save your life with using all the parts of our body. The cardiac way of compensating, this patient has a decreased cardiac output. And so, of course, the heart rate tries to increase. So you have an increased pulse or tachycardia, unless it's neurogenic shock, and then you have a low pulse. But the cardiac way of compensating is an increased pulse. The problem with the cardiac system is this body is going through hell right now, and it's retaining potassium, and the retention of potassium can often cause dysrhythmias, because remember, the only way to get rid of potassium is to pee it out, and we're having a lot of fluid retention, and so now our K is kind of, high and can cause some dysrhythmias. So that's our issue there. With the extremities, I already told you, the arms, the legs, the blood is shunted away. Well, I mean, depending on what's going on with your extremities and any pre-existing microvascular disease, you could end up going into shock and needing an amputation of one of these limbs, because we're not perfusing blood to these limbs, to these extremities. We're not. We don't care if you walk right now. You're sick as a dog. You might die. Walking's not a priority. Okay, so that's why the blood is shunted away. And I'll give you an example of that. I had a young lady in my class who was a referral from another young lady in my class. And the young lady in my class that referred her, Ariane, hi Ariane, she has a mom that got admitted into the hospital with the flu and never came out for months. And when she did, she had an amputation. And this girl that was referred to me by Ariane, as I was teaching this in class, she jumps out of her seat. She goes, oh my God, now I understand why Ariane's mom went in with the flu and came out with an amputation. I thought the hospital made a major mistake and did something really bad. Like, how do you go in with the flu and come out without a leg? And I said, absolutely. The flu and actually respiratory infections, gastro or GI infections or surgery, and GU or genital urinary infections, all are the top causes of septic shock. And if you go in with the flu and you come out without a leg, you better believe that that was related to the effects of the compensatory stage of shunting blood away from extremities. So there you go. So here we go. Shunting, decreased circulation and perfusion. That extremities are going to be pale and clammy and cool. Even mottled is sometimes what we see. The brain during this time is going to have decreased cerebral perfusion pressure, CPP. Oh, CPP. CPP due to MAP. MAP. Okay, I know, I'm sorry. Decreased cerebral perfusion pressure is directly related to the decrease in the mean arterial pressure, which was directly related to decreased blood pressure, which just means if you don't have any blood pressure, you don't have any blood perfusing the brain. Common sense shit, but they give it big old flowery $4 words just to fuck you up, I guess. I don't know. Decreased cerebral perfusion, right? Okay, decreased cerebral perfusion pressure just means decreased blood to the brain, and your ass gonna have a behavioral change like anxiety, irritability, confusion, altered mental status, apprehension, feeling of doom, restlessness, or something, right? You know those words. Okay. Now, let's switch up the game. Let's take a look at how compensation, if the nurse and the doctor does not catch this stage and treat the patient right here, which is the best time to treat them in the compensatory stage. If we don't recognize all of these signs and symptoms that I just gave you, we're going to progress into something worse, right? What are we progressing to? We're progressing to, boom, progressive stage. Oh boy, this is where things get really bad. Yeah, things are starting to progress, not for the better, but for the worse. So here we go. When you have neuro issues, and remember, we started off with neuro, trying to compensate, but eventually even the nervous system is not going to be perfused. No neuro, no muscle. Just remember that nerves innervate muscles. If you don't have any nerves, you won't have any muscles working for you. Okay. The kidneys or the renal, as they're trying to compensate, if that fails, we're going to end up with acute kidney injury as a result of acute tubular necrosis. Our K will be very high. Remember when we write words like this, watch this. When we write words like this, C, K, D, A, K, I, there's one more, D, K, A, the potassium is usually high. Now with DKA, it could go either way, but just a little trick. AKI, CKD, and DKA, the K is high, right? So you know. All right, now, when it comes to the GI system, having the blood shunted away from it, this can end up being a bowel resection and the patient having a permanent colostomy. When the respiratory system decompensates, gets worse, not doing quite well, the patient may need to be intubated and ventilated. When the patient has skin that is not getting perfused very well, cool and clammy and pale, we may end up with necrosis, pressure ulcers, infections in the wounds themselves, even amputation because it goes and infects the bone. You know how this is. If we have problems with the liver is really, really bad. If the liver is decompensating the way we know it can, then we end up with what's called DIC, disseminated intravascular coagulation, because the liver controlled clotting factors. Now we have all these clotting issues and bleeding issues because eventually we run out of the clotting factors. And let me just say, when you have a patient with DIC, they're going to be bleeding from every orifice, like the mouth. You know, if they're intubated, you're going to see blood coming out of that tube. Any kind of core pack, NG tube, blood. The tear ducts can bleed. The ears can bleed. The patient can have bleeding from their central lines. The patient can have bleeding vaginally through the urethra. The urine is tea colored. They could have coffee ground emesis, a GI bleed. They can have rectal bleeding. Everything is bleeding, guys. Maybe you gave your patient an injection, an IM injection yesterday. That's going to start bleeding. The Foley's going to drain blood. Any chest tubes are going to be draining blood. Everything is bleeding. The number one early sign is oozing at the IV site. Watch those IVs, please. Oozing at the IV site, earliest sign. Okay? All right. Now, when the lungs start to decompensate and just go downhill quickly, that collapse of the alveoli that leads to atelectasis because the body is filling up with so much fluid. This fluid is going to further collapse the alveoli and cause the patient to have ARDS, acute respiratory distress syndrome, ARDS. The patient's cardiac system starts to decompensate. That's going to become progressive in its damage. Now we can have a cardiac arrest or even an MI. Lots of dysrhythmias are possible as well. Extremities that are not getting any perfusion can end up being amputated. And of course, our brain is like mush. We are altered mental status, slurred speech if we're still talking, which for the most part you're not, decreased LOC. And if all of this gets this bad, where all of these are happening and all of these have happened, this is called the last stage, stage 4, the refractory stage. And the refractory stage is irreversible. This is where you're guaranteed death and there's not a damn thing I can do about it because of multiple organ dysfunction syndrome. So you know what I'm going to say. You know I'm going to say our job is to stop this at its tracks, to understand that cool and clammy is not good, to understand that the different types of shock have distinct symptoms that we should be able to recognize, to understand that tachycardia may be early, but low blood pressure is guaranteed, okay? So I hope that helped. Now, when we do another video, we'll talk about the whole endothelial injury and capillary permeability and all the rest that goes with it. But that's very specific information, and I wanted to keep it general because even just keeping it general gave you 52 minutes of God knows what all, right? Now, lastly, don't forget to vote. I'm an early voter, so I'm planning on going on next week, Tuesday, and doing my thing with my cousin. We make a tradition out of it. Get your ass up and vote. There's only one person addressing the needs of the country instead of the needs of themselves. And I, for one, love the idea of giving $25,000 down payment to wonderful people like yourself so you can buy a home. I love the idea of a $50,000 tax credit to start up a company because all of us have talent and we all have something we do better than anybody else. And if we can make it a business, including a YouTube business, there's a $50,000 tax credit waiting for you. I love the idea of when you have a baby getting a $6,000 tax credit and the fact that somebody gives a shit if you're paying too much for daycare. But all of these programs are only being proposed by one candidate. I'll let you take a guess. It certainly is not the son of a bitch that is concluding that people are eating your dogs and your cats. Deuces, love ya.